Hi, everyone. Welcome. My name is Dr. Bridgette Kelleher. I'm an associate professor of psychological sciences at Purdue University. I also co-direct our Purdue Autism Research Center. I'm joined today by my co-chair, Dr. Ann Wheeler, who is a senior public health research analyst at RTI International. And we are thrilled to share with you our symposium, What is the Need and What Do We Do? Innovations in Assessing and Treating Families of Individuals with Neurodevelopmental Disorders During COVID-19 and Beyond. So as you all know, COVID-19 has radically shifted all aspects of family and community life, but this is particularly true for families of children with disabilities. And so in our symposium, we're going to take this concept from assessment to intervention and think about it from multiple angles. And so to give you a preview of what we'll share with you, Dr. Ann Wheeler is going to start us off by sharing some really interesting data documenting the need among caregivers of children with disabilities who are reporting greater mental health risks and stress than caregivers of children without disabilities. I'm then going to share some data that follows our longitudinal cohort of families who we had collected data on prior to COVID-19 to share how relative to their pre-pandemic baseline, caregivers of children with rare disorders are reporting higher mental health outcomes and stress, particularly those who have increased caregiving burden during COVID-19. We'll then hear from postdoctoral scholar Anita Panjwani, who will share her data on how among families of children with autism, high levels of food-related challenges are being reported, particularly among those who have fewer resources. And we will conclude with a presentation from Meredith, Bucher, and Eric Shannon, who are graduate students at Purdue University, sharing data from our telehealth intervention that we conducted this summer during COVID, documenting that it's an effective and feasible option for supporting caregiver mental health and parenting competency during COVID-19. You'll notice across these talks that there are some key innovations that I want to draw your attention to. So Ann Wheeler is going to share a technique called best worst scaling, which gives us kind of a different way of measuring the magnitude of preferences and needs among caregivers. Our data in my talk is going to highlight the use of ecological momentary assessment, or a smartphone-based method for collecting data via pings that we send in these 3-minute bursts to caregiver phones throughout their day, which lets us learn more about the texture of their experiences on a day-to-day basis. Dr. Panjwani is going to share with you some information about how poverty intersects with the experiences of families with disabilities, which is a really important and underrepresented topic in the literature. And Meredith and Eric are going to highlight the power that can come from pursuing interdisciplinary treatment. Specifically, we partnered our clinical psychology training program with our special education training program to bring an integrated treatment approach to families, and they're going to share how that went and how it worked out for our enrollees. And so you'll notice that some of our talks are focused on identifying the needs, some are in examining individual differences, and finally, we orient to taking action. So here you can see our lineup across the symposium. We're really excited to share this work with you. And then we are looking forward to a wonderful discussion by Dr. Elizabeth Jalazo, who is the Director of Clinical Integration for the Angelman Syndrome Foundation. She's also a pediatrician at the University of North Carolina at Chapel Hill and a caregiver to a child with Angelman syndrome. And so she'll share some final thoughts that will orient us toward our discussion. Thank you.
Hi everyone, my name is Ann Wheeler. I'm a psychologist and researcher at RTI International, and I'm here to describe to you all some results from a nationwide survey that we conducted just after the start of the COVID-19 pandemic. Our intention with this survey was to really understand how the COVID-19 pandemic and related closures may have had a differential impact on families of children with special needs versus those who have no children with special needs. So this survey was part of a larger study called the Family Risk and Resilience in Response to COVID-19 study. And this was a collaborative effort between myself, my colleague Holly PA at RTI, and Bridgette Kelleher at Purdue University. It was launched in April 2020, and it involved 2 phases. The first phase is the work that I'm going to describe to you in this presentation. And this was a national survey open to anybody over the age of 18 with at least one child under the age of 18. We recruited through social media, disability advocacy groups, as well as existing cohorts from studies that Dr. PA, Dr. Kelleher, and I were currently running. And this was a one-time data collection, so we didn't have identifiable information to recontact these families, with the exception of a subgroup that did sign up to learn more about the second phase of the study, which was primarily open to participants in Dr. Kelleher's ongoing study on kids with neurogenetic syndromes. But they also included some children with who were matched controls who do not have neurogenetic syndromes. And the purpose of this part of the study was to understand longitudinal changes in well-being in families of kids with neurogenetic syndromes using ecological momentary sampling and regular surveys completed over a 7-week period. And Dr. Kelleher will be talking a little bit more about that phase in the next talk. So the phase 1 survey had 4 components. We asked about household composition. We wanted to know about specific needs of the child, and we asked families to complete information for each child under the age of 18 in the home. And this included information about the child's education and childcare situation, what types of special needs the child might have, and whether or not those special needs increase their risk for COVID-related issues. And then we asked a series of questions about whether or not the parent perceived increases or decreases in specific child behaviors as a result of the COVID-19 pandemic and closures. We also asked parents to describe their own caregiving responsibilities, their employment and income, and what their experiences had been and concerns about COVID, and their responses to the pandemic, as well as understanding their overall well-being and orientation to life. Finally, we asked some questions using a best-worst scaling survey where we asked families to weigh different types of statements associated with worries about COVID-19 and indicate which items were the higher worries for them versus those that were less concerning. So our sample consisted of 512 respondents who reported on a little over 800 children. We, for the purposes of this presentation, have excluded all of the children under the age of 3 because we had a higher sample of very young children that skewed our comparison groups between those with and without special needs. So as a result, we are reporting here on a little under 500 children, about a third of whom had some sort of special need. And the sample was primarily white, but the income was relatively spread among different categories. About 15% of the adults that reported had an increased risk for COVID-related concerns. Within the children, there were about a quarter of them who were reported to have an increased risk for health-related issues as a result, if they were to be infected with COVID. Of the children who had special needs, the vast majority of them had some sort of intellectual or developmental disability. These are not mutually exclusive categories, so families may have chosen more than one here, but you can see that they are more heavily populated with developmental disabilities or genetic conditions, which is just a factor of our recruitment process, recruiting from cohorts where we are primarily studying neurogenetic conditions. You can see about a third of them also have or solely have issues related to medical concerns. About 3/4 of the sample reported that their child's school was closed and the child was receiving online learning. And about 14% reported that the school had closed with no online learning. And this was disproportionately seen in the sample of children with special needs. Importantly, almost 70% of our sample reported being somewhat or extremely dissatisfied with how their child's school had responded to the pandemic, which was likely a reflection of the stress that the families were experiencing at that time. When we asked about behaviors, we see that while there were increases in behaviors among both groups, those with special needs and those without special needs, pretty much all of the categories were significantly more common in children with special needs. We were also interested in whether or not there would be age-related differences in the increases in behavior, and we did see that. With children with and without special needs, the younger cohort tended to be reported to have more tantrums, whereas the older cohort was more likely to be reported to have increases in changes in sleep. Among the children with special needs, we also saw an age-related difference in anxiety, with older children being more likely to be reported to have increases in anxiety. Whereas with the no special needs group, we saw increases in aggression, hyperactivity, crying, and clinginess to be more common in younger children, whereas withdrawing was more common in older children. Distractibility, self-injurious behaviors, repetitive behaviors, obsessive thoughts, and compulsive behaviors were also significantly different across the groups, but this was more of a factor related to whether or not the child had a special need versus age. It shouldn't be surprising to any of us here that we did find that parents of kids with special needs reported higher levels of depression, anxiety, and stress. And I won't talk more about this, as I know Bridgette will be talking more about these findings in the next presentation. So I want to spend some more time talking about our best worst scaling choice task. So the way this is set up is that families were asked to rate among a series of objects. In this case, they were statements about worries related to the COVID-19 pandemic. And on each page to indicate which of those they were most worried about and which of those they were least worried about. And they had a series of these, about 11 items, where the different items within the question were randomly sorted so that they had forced choices among the different items. So the items that were included in the best worst survey included some items that were related to relative risk for different individuals in the home's health. Also, we had items related to loss of services or closures, items related to medical concerns and childcare and access to childcare, items related to financial concerns, and items related to psychological well-being and long-term impact. So here's how the results are presented. So you can see here that the top concern for both families with children with special needs and without was COVID-19 related risks to their child's health. But that's as far as the results are comparable. Beyond that, there were differences. So the second most concerning area for families who do not have any children with special needs was COVID-19 related risks to other people, so not their children. Whereas the second most concerning statement for those with special needs was whether or not their child would need medical care and have a resulting exposure to COVID. Then we also had some differences in relative risk among the groups that included things like families without special needs indicating a higher concern for uncertainty about the future, whereas families with a child with special needs were more likely to indicate things like loss of services or activity for their child as being a significant worry. So in summary, our survey found that in the months following the COVID-19 pandemic, that children with special needs were more likely than those without special needs to have increases in both internalizing and externalizing behaviors, that parents with special needs were more likely to report elevations of depression, anxiety, and stress. The parents of children with special needs were more likely to report worries related to losing services for their child or their child being exposed to COVID than parents of children without special needs. And parents of children without special needs were also more likely to report worries related to the future after COVID. So this survey seems to indicate that families of children with special needs did in fact differentially experience stressors related to the COVID-19 pandemic, which is of course not a surprise to any of us. But it does point to implications for how we provide services and how we think about preparing for future stressors and knowing that there may be disproportionate things that needed to be addressed for families of children with disabilities. Thank you for your time. I look forward to answering any questions that you may have during the Q&A for this presentation.
Hi, everyone. My name is Bridgette Kelleher, and I'll be sharing with you some of our data on how caregiving burden relates to mental health among caregivers of children with rare syndromes during COVID-19. So to get us started, as Anne mentioned, families of children with special needs are really experiencing some unique challenges during COVID. But we also know that the impact of the pandemic on any given person really reflects a number of different axes of risk that intersect and change over time. So for example, when we're thinking about one person in our study, they're falling on these continua of whether or not they have full school services or e-learning, whether they have any social support, whether they're dealing with compounding trauma of racism, whether they're dealing with high employment demands or whether they're having trouble finding a job at all that's safe for them to do during this time. And these factors also change over time. So it's a really complex system, and it's important that we understand how individuals are responding in addition to understanding these group trends. So in this study, I'll share 2 research questions with you, and this is the tip of the iceberg for a broader project that I'll describe. But first, I wanted to look at how self-reported COVID stressors like caregiving responsibilities, stress due to COVID, social isolation relate to caregiver mental health changes since pre-pandemic baseline. So we're using a longitudinal data set here that we've been following these families for a number of years, and we had pre-pandemic data. Second question is, how do these stressors relate to fluctuations in their stress and mood throughout the day, as measured using ecological momentary assessment, in which we had an app that sent pings to their smartphone that collected data on specific questions about their well-being and their stress and what they were doing at that moment, substance use, health behaviors, sleep, all sorts of things. So this is just a first pass at some of these data. So participants here were 50 families, caregivers of children with rare syndromes. The study is ongoing. Here I'm focusing on the 50 that were enrolled in our previous study because we had pre-pandemic data on them. They were predominantly white and highly educated, so this is a pretty homogeneous majority sample. The data I'm presenting to you today were collected April to July 2020, so kind of peak pandemic, and here I'm focusing on the first 7-day period of this window for each family. And in the broader study, there were 4 biweekly surveys they participated in, and then 4 7-day periods of EMA data, where 4 times a day they got pings to their smartphone that asked them a series of questions that totaled no more than 3 minutes. Our missing data rates were pretty low, and here are some of the measures that I'll focus on today. So in terms of single items that we asked families that I'm kind of zooming in on, here you can see how we measured COVID symptoms. So to what extent has the COVID pandemic caused you stress? How has your caregiving responsibility changed as a result of COVID? How much caregiving responsibility do you currently have? And in comparison to COVID pre-pandemic, to what extent is your family practicing social isolation? And if we start by just looking at how their mental health has changed, you can see that on the DOS-21, we get 3 domains: depression, anxiety, and stress. And the median change from their last assessment prior to COVID to their first assessment during COVID really varied amongst individuals. You can see negative to positive, which means some are increasing in symptoms, some are decreasing. To the right here, you can see the proportion that fall in each category: decreasing, staying the same, or increasing. And I'll just draw your attention to stress, because this is where we saw significant increases across the sample. This doesn't mean that nobody was getting more depressed or anxious, just that as a whole, the group wasn't shifting in that direction. With stress, we're seeing this shift. If we then look at how their kind of single item responses in terms of their COVID experience relate to these levels and shifts, kind of in the first column here, you'll see their current symptoms. These are just how are these predictors correlating with how they're saying they're feeling right now. And then on the right, the next column over, you'll see the predictors of symptom change. So how are they correlating right now, controlling for where they were before? And we see that again, this current stress caused by COVID, kind of this broad item, is predicting higher levels of depression, anxiety, and stress, as is saying that they have substantially more caregiving now than before COVID. And this is interesting because we see a less robust association with just their levels of caregiving responsibility. So we see that those who have full caregiving responsibility are showing higher levels of stress, but not like fully robust changes in depression or anxiety. Similarly, when we look at what is predicting increases in these mental health symptoms since before COVID, current stress due to COVID, kind of this broader factor, is predicting higher levels of depression, anxiety, and stress, controlling for folks' baseline. And interestingly, substantially more caregiving is also predicting higher levels of anxiety. Notably, just full caregiving responsibility in general, so folks that just have more caregiving responsibilities, irregardless of what kind of they were doing before COVID, those folks are not showing the same increase in mental health risk. We next looked at how those 2 most salient factors, so here COVID-related stress, just overall item, and then also change to caregiving responsibility related to their daily reports of stress and negative affect as measured on pings on their smartphone. On the left here, you can see what their stress looks like during the week. So our caregivers are a lot less stressed on the weekend. They're the most stressed in the morning. I think I show this just to show you that there's real value in looking at these more textured responses versus these once a week measures where we might hit people at different points of the cycle, right? And then on the right, if we look at the outcomes and how they relate, we found that stress, so when we asked them on their phone, how stressed are you right now? Those who said COVID is providing a lot of stressors in their lives are reporting more stress in their daily life, which might not be surprising. But so are the folks who say that their caregiving responsibilities have changed. Similarly, with negative affect, we see that those who are saying their caregiving responsibilities have changed are reporting more negative affect through their day. It's not the same with the COVID overall stress. So what do these data mean? First, we're seeing that caregivers are more stressed during COVID than they were before, but we're really seeing variability in individual patterns of depression and anxiety. So this goes to show that we really do need to look at individual differences when considering how to identify and support caregivers in need. I think the most important take-home point is that caregiver burden change, not absolute level, is uniquely predicting negative affect and stress. So it's not necessarily the case that folks who may have been stay-at-home parents before or had a lot of caregiving responsibility before COVID, that they're having the same experience as those that have had this change, either due to the loss of services or changes in employment. And so we really need to consider folks' pre-pandemic baseline when deciding how to offer care. I also want to flip this and note that more parenting isn't necessarily bad for people, right? Like parenting, bonding with your child can be a really positive experience. And I think during COVID, this has gotten mixed messaging in the media. And these data, I think, really speak to that it's a unique stress associated with shifts in responsibility that may be paired with lack of support or access to services, rather than just spending more time with your child. I also want to highlight that EMA data can provide this really unique, convenient, and textured lens into the experiences of caregivers. And I'm really excited to look further into how this might be helpful in terms of circumventing some of the limitations in our clinical tools, and potentially catching folks who need support that are underreporting on clinical measures. For example, if you look at our sample, about 16% of folks who are below threshold on the DOS, which is our clinical tool, show greater than a standard deviation and a half above the mean on these EMA metrics, suggesting they may be underreporting their weekly symptoms, but still experiencing pretty substantial stress and negative affect during their day. A few of our next steps, we're now working on caregiving, characterizing broader experiences across the pandemic. So you can see posters by Taylor Halligan and Tyra Protho, where they'll go into more depth on some of these other papers that are in development and some updates on our sample. We're also working really hard to improve representation of diverse voices in our sample. We understand this is a highly homogeneous group, and Cameron Dartis, who's an undergraduate, received a grant from the Purdue Autism Research Center to try to expand this cohort to include more Black caregivers and add some items specific to their experiences. So we're working on that now. And then we're also interested in understanding, again, how these EMA data could potentially optimize treatment outcomes. So we have some projects under review to try to use the rich textured responses of these EMA cohorts to better understand who's at risk and what kind of support they might need. So thank you very much for your time. Thank you to this wonderful team that has supported this and my other projects, and specifically to the Purdue Health and Human Sciences COVID Rapid Response Grant and Discovery Park Big Ideas Challenge for funding this work. Thank you.
Hello, everyone. Thank you again for joining us today. My name is Anita Panjwani, and I will be presenting on my research, which was a collaboration between the Kelleher and Bailey labs here at Purdue. My talk today will focus on the impacts of COVID-19 on children with ASD, specifically on behavioral outcomes related to food environments, and also highlighting some of the disparities seen in our data. So the research questions for the study were, what are the impacts of the COVID-19 pandemic on the overall behaviors of children with ASD? And then asking, what are the impacts of the pandemic on food-related outcomes and behaviors? And these include eating behaviors as well as food access, so difficulty in finding foods that the child usually eats. And finally, what are some of the potential roles of demographic and socioeconomic factors in moderating the risk of these outcomes? So this was a nationwide online survey of 200 parents or caregivers who were served as proxies for their children with self-reported ASD. The survey was conducted during May and June of 2020 at a time when most states were under a shelter-in-place or a stay-at-home order. We obtained information on caregiver and household characteristics as well as child characteristics. And the main outcomes included impact on overall behavior, eating behavior, and food access for our research questions. And then we reported descriptive statistics, and conducted logistic regressions to model the outcomes. So starting with the behavioral outcomes, close to 75% of the respondents reported a moderate to large impact on overall behavior of their children post onset of COVID-19. And over 57% reported a moderate to large impact on the eating behaviors of their children. Then we have difficulty in finding foods the child prefers or usually eats, and we see that 65% of caregivers responded that they did have difficulty in finding foods for their children. So coming to caregiver and household characteristics, I won't go through all the numbers here, but we see that 77% reported to be under some sort of shelter regulations, and 75% reported living with a spouse or a partner. And this was actually significantly associated with impact on overall behavior. So among those who reported not living with a spouse or partner, a higher percentage reported a greater impact on their child's overall behavior. And then when we look at the impact on eating behaviors, this was significantly associated with being under shelter regulations, which overall behavior was not. So that was interesting to see that, it had an impact on eating behaviors, but not overall behavior. Okay. So continuing with parent and caregiver characteristics, we see 46% reported earning less than 50K for household income. 38% reported loss of employment or reduced pay for either or both caregivers, and food security insecurity status was around 60%. And as we see here, all of these characteristics were significantly associated with the impact on overall behavior of the children, and they were all in the direction that we were expecting to see. And then looking at eating behaviors, the only one here that was significant was post-onset of COVID-19 food insecurity status. But I do want to point out here that, we shouldn't discount the other characteristics, because while the p-values aren't significant, they're small enough to be worth exploring further. And then coming to child characteristics, we see that 76% were male, as we would expect. The average age of the child at the time of the survey was 7.7, and the age of diagnosis was 3.7. Looking at race, the majority of children were non-Hispanic white, with some representation from the other races there. And then I'm showing all of this together here because we didn't see any significant impact on overall or eating behaviors by any of these characteristics. But I do want to point out here that for the age of diagnosis, there was a marginal significance on the impact of eating behaviors. So here we see that children who had a greater impact on eating behaviors were on average about a year older than those who didn't have such a large impact on eating behavior. So that may be something worth looking into further in terms of early interventions. And then here we have weight status for the children. We see here that 26% were obese, around 16% were overweight, another 16% were underweight. For educational setting at the time, 63% were receiving virtual instruction, while 30% were receiving no instruction. And this included children who had access to virtual instruction but couldn't take advantage of it at the time due to various reasons. And again, here we see no significant associations with impact on child behaviors. Now coming to logistic regression models, here we're looking at the associations of moderate to large impact on the regulations of overall behavior among children with ASD, with shelter regulations, food insecurity, household income, and loss of employment. So while there was no association with shelter regulations, the associations with food security, both prior to and post onset of COVID-19, with post onset food insecurity having a greater association there. And then if we look at household income, the odds ratio there was also around 4, and that was only significant for those earning less than 50K compared to those earning 100K or greater. And that again was really highly significant. And then similarly, you see the same magnitude of effect and significance level for loss of employment there. Looking at eating behaviors, you'll see here that shelter regulations were significantly associated, as we saw when we were looking at the descriptive statistics, and the odds ratio there was 2.3. And then food insecurity status post-COVID-19 was significantly associated, whereas pre-COVID-19 was not quite significant. And then again, we see the lowest income group here was significantly associated compared to the highest income group, but loss of employment was not associated with impact on eating behaviors. And then coming to food access, here we see food insecurity, both pre and post again, were significant, and the odds ratio was around 4 compared to what we saw for overall behaviors. But here we also see for household income, both the lower level and middle level were significant compared to the highest level of income. And the odds ratios were at 3.5 and 4, both significantly associated again. And then for food access, loss of employment was not associated, and nor were shelter regulations there. So I wanted to discuss here the existing literature from Italy and Portugal. So there's no existing studies in the US right now. And so these two studies also reported impacts on overall behavior in line with our findings, around 76-ish%. However, the study in Italy, while the wording of the questions may have been slightly different for eating behaviors, we did see a large difference there with greater impacts on eating behaviors among the families in our study compared to the ones in the Italian study. Previous research in food security has shown that having chronic exposure to reduced access to nutritious foods can have detrimental effects of nutritional status, and that can carry over into adulthood. And individuals with ASD are already at risk for chronic diseases, so this would be another compounding factor there. COVID-19 has also amplified disparities by income and food security status on all families. However, greater burdens fall on ASD families. And so there's really a need for wider systems-based approaches, including resolving issues of accessibility and affordability of nutritious foods, having access to proper healthcare, and autism-specific services as well, including diagnostic and early intervention services. So thank you for joining the session, and we look forward to your questions.
Hi, everybody. My name is Meredith Bucher, and I'm going to be presenting today with Eric Shannon to talk about a virtual treatment network that was designed to meet the needs of Angelman syndrome families during the COVID-19 pandemic. Angelman syndrome is a rare neurogenetic disorder with an estimated prevalence of about 1 in 50,000. It's characterized by significant developmental delays and medical difficulties, and individuals with Angelman syndrome require care throughout their lifespan. While caregivers have many positive caregiving moments with their child with Angelman syndrome, providing intensive long-term care can have negative consequences on their mental health. It's also important to highlight that there are some significant barriers to treatment for caregivers of children with Angelman syndrome. First, due to low incidence, children with Angelman syndrome tend to not live near medical professionals that have training on their specific condition, leaving their families often in the care of providers with limited knowledge or training in the difficulties that they might have. A second consideration is the challenge families face in finding access to adequate childcare or respite coverage necessary to attend something like personal therapy sessions for themselves. COVID-19 has further exacerbated these barriers and also increased stress and caregiver burden among caregivers, including those of children with special needs. So our study, through a larger project called Project Wellcast, sought to specifically target interventions for caregivers of children with Angelman syndrome through video conferencing telehealth services. Our first goal was to develop a caregiver-centered model that ensured clinicians were trained to deliver treatment and understood the unique needs of Angelman syndrome caregivers, as well as to reduce barriers that might have otherwise prevented these caregivers from accessing appropriate tailored services. Our second goal was to examine the effectiveness in improving the mental health symptoms among caregivers of children with Angelman syndrome. And we did this through two primary interventions. The first is acceptance and commitment therapy, or ACT, which I'll be talking about. And the second is enhanced milieu training, which Eric will be talking about. So ACT focuses on validating difficult thoughts and improving one's acceptance and mindfulness of current life situations that can't be changed. It's well suited for caregivers whose thoughts might actually be considered pretty normative in the context of their lived experiences, but who might also benefit from support in coexisting with these thoughts. In our study, we had 17 caregivers who completed the ACT intervention, 3 of which also were participating in EMT at the same time. We had 7 graduate level clinicians who provided those services under a trained licensed psychologist. The intervention was 9 60-minute sessions that centered around the 6 processes listed here related to ACT. And caregivers also completed multiple assessments throughout the intervention that examined their levels of depression, anxiety, stress, emotion regulation, general well-being, as well as their parenting stress and parenting competence. Caregivers were asked to rate their overall experience after the intervention was complete, and as you can see, they reported overall positive experiences related to the overall study, as well as the ease of technology, the personal comfort with the intervention, support from the research team, and treatment materials. Caregivers were also asked to compare the intervention to those offered in their local communities, and they all reported that this intervention was either the same as, better, or much better than those offered locally. We also looked at overall mental health, and while not significant, there was a small effect for increases in general reported well-being after the intervention was over, which we might not have had enough power to actually detect this change, but suggests that there definitely was a slight increase there. There was a significant increase in parenting competence, such that the caregivers reported higher levels of parenting competence at the end of treatment. And although not significant, it was an overall medium effect, suggesting that caregivers were reporting decreased levels of parenting stress after the intervention. We also administered a measure that looked at depression, anxiety, and stress at every session. And using repeated measures ANOVA, we found significant changes in depression, particularly between weeks 1 and 9, suggesting that caregivers were reporting significantly lower levels of depression at the end of treatment. There are a lot of numbers here, but to sum, across the 3 groups, they were all administered the depression, anxiety, and stress scales throughout the intervention. And the big takeaway here is that in both the ACT and EMT only groups, there were small to large decreases in depression, anxiety, and stress, which can be seen here by the overall effect when comparing week to week. In the ACT plus EMT group, there was also a pretty quick significant drop in depression, but you don't quite see that same pattern for anxiety and stress.
In addition to mental health outcomes, our study examined the effects of a telehealth parent training program focusing on naturalistic communication in the home. This intervention is based on the theory that learning is most effective when it occurs in a child's natural environment during typical daily routines, and it involves adults responding to highly motivating, child-driven opportunities for communication use. We utilized a modified version of a specific naturalistic communication intervention for early communication development called Enhanced Milieu Teaching, or EMT, which consists of 3 primary components: modifying the environment to encourage communicative interactions, responsive interactions that follow the child's lead, and using behavioral strategies such as modeling and prompting language use and providing natural reinforcement. 3 families received parent training on enhanced milieu teaching strategies alone, while 3 families simultaneously received EMT parent training and the ACT mental health intervention. Families chose a primary routine in which to receive coaching on, and a secondary routine in which we assess if strategy use was generalizing. Play was chosen as the primary routine for most families. Participating families were mailed tablets preloaded with necessary apps and password-protected training materials. Coaches and parents met for a 60-minute intake session to gather background information and identify target routines. Families were asked to record 3 5-minute videos per week of them interacting naturally with their child, twice during the primary routine and once in the secondary routine. After baseline, training materials were unlocked and parents were instructed to watch 4 15-minute modules. In addition, parents began receiving weekly 30 to 60-minute coaching sessions. Coaches and parents collaborated to identify strengths and needs and developed goals and action plans. Coaching continued until parents reached mastery criteria of correctly implementing at least 85% of EMT strategies across 3 consecutive primary routine sessions. Maintenance was assessed 4 weeks later, with parents uploading 1 video each of their 2 routines. Here we have the results from both treatment groups. On the y-axis is the percent of correct fidelity steps completed by the parent, and the session number is on the x-axis. Circles represent primary routine sessions, and triangles represent secondary routine sessions. All parents within each of the treatment groups saw immediate increases in fidelity upon introduction of the intervention and reached mastery criteria within 3 to 5 weeks. Generally, fidelity during secondary routines increased as well, although these effects were not as substantial or consistent. Of the 5 parents that uploaded at least 1 primary routine video in maintenance, only 1 required a booster session to return to mastery criteria. Overall, these results are encouraging and demonstrate that a low-intensity and short-term parent training program can increase caretakers' use of strategies that encourage early communication development in their children. Analysis of child outcomes is ongoing. Because of the age and population of the child participants, our original measure was not sensitive enough to pick up on subtle changes in communication use. We are working with a team from the University of Kansas to use a far more sensitive scale and should have those results in the coming months.
Our results show that our project was able to effectively provide telehealth services to caregivers who otherwise had limited access to these services in their communities. Both ACT and EMT are effective treatments for caregivers of children with Angelman syndrome, as both resulted in significant decreases in depression, anxiety, and stress. We also just wanted to highlight the resiliency of the caregivers who participated in this study, especially as they navigated caretaking during a pandemic with many unknowns. And we also wanted to take a moment to thank everybody who made this study possible.
Hi, I'm Liz Jalazo, and I'm thrilled to be here to wrap up this talented group of clinicians and researchers who've displayed their tireless work over the last year for families like mine. I'm a pediatrician by training, caring for children with complex genetic disorders at the University of North Carolina at Chapel Hill, and the clinical director for the Angelman Syndrome Foundation. But my greatest role for sure is that mom of 3 beautiful children, one with a complex neurodevelopmental disorder. Evelyn is 6 years old and has Angelman syndrome. So we are no stranger to the unique stressors this pandemic has brought for special needs families like ours. I wear many hats daily: parent, advocate, clinician, but perhaps where one of my greatest expertise lies maybe in finding the silver lining. As parents of children with complex healthcare needs, we are not strangers to finding the silver lining. As a clinician, and particularly as a geneticist, it's something I have the pleasure of seeing almost daily. COVID-19 and the physical, psychological, and emotional toll the last year has brought has felt insurmountable at times. Our communities, schools, therapeutic services, activities, and the usual supports required to keep families like mine afloat all but disappeared overnight a little over a year ago. But what have we learned, and are there silver linings? And of course, I'd argue there's at least a few. At the risk of sounding trite, I really do believe this to be true. While we found ourselves isolated physically, I'd argue we've simultaneously found ourselves both as physicians, service providers, therapists, and parents more accessible, perhaps more accessible than ever before, and perhaps to a fault at times. And the incredible approaches and tools presented today, many in the works fortuitously long before the unprecedented pandemic descended, but really given the chance to shine in challenging times, are just a few examples. Dr. Wheeler and her team have demonstrated the incredible wealth of information that can be gathered virtually without interfacing with families, at least in the traditional ways we're accustomed to. We've seen today that the individual hardship and the impact of a shared experience on a certain community can be eloquently described without our typical access points to patient populations through the clinics. This also highlighted the importance of collaboration between patient advocacy groups and researchers and alternative avenues to reach families through social media and other platforms, allowing opportunities to work towards closing that gap in racial and ethnic disparities and accessing healthcare and research opportunities. COVID has given license and a sense of urgency to develop platform technologies to quickly deploy assessment tools and remote therapeutic intervention tools to reach families in need. The unique focus on assessing disparities in food-related outcomes and difficulties with food availability for families in whom feeding behaviors represented a huge source of stress pre-pandemic is really fascinating. Whether these food access issues stem from financial hardship or behavioral restrictive eating patterns, or specialized diets like the one that Evelyn is on, this pandemic really posed risk to all. And these findings that we saw today really represent an opportunity to inform future policy to reduce these negative impacts on these families that perhaps aren't immediately recognizable to policymakers. While I can't wait for the day to hug those valued members of our family and clinical team and welcome them back into our home, I don't miss the days of 4 a.m. up and back flights to Boston to see specialists. And I can assure you Evelyn doesn't either, though the cab ride from Logan International to Mass General is thrilling and always a highlight for Evelyn. Born out of necessity, telehealth has emerged as an innovation that many providers and families are eager to keep around. And a year in, while we're not half bad at it and the popularity of this modality has increased, there's still much work to be done in deploying evidence-based treatments in this format. Drs. Kelleher and Lemaire have demonstrated the power of these tools to assess caregiver mental health and pinpoint the pain points contributing to caregiver stress in these challenging times. Utilizing push notifications, pings to personal devices has not only reduced the burden on families, but highlighted the robust real-world evidence or real-world data that can be collected when the delivery tool is thoughtful and intuitive, as well as proof of concept work that suggests telehealth treatments can be an effective model for decreasing barriers and increasing accessibility in this vulnerable patient population that was at risk for high stress at baseline, and certainly during a pandemic like COVID-19. Moving clinical care and even clinical trials out of the clinic and into the home is not just a wild hair idea anymore, and it's becoming more and more mainstream. While a record-breaking number of trials were halted or shut down in the first half of 2020, a recent New York Times article highlighted several examples of studies that were able to pivot and even improve recruitment and participation by utilizing remote assessments. For patients in vulnerable populations, this has become even more imperative. While we will be thrilled to see this virus recede and hopefully science get a win here, how do we ensure that these lessons and tools are not lost with COVID? The imperative is really twofold as I see it, falling both on researchers to continue to hone these tools to reach those most at risk, but also now turns to legislators and policymakers to ensure access to these valuable tools and that these efforts were not in vain. It was said sometimes it takes a crisis to provoke change, but I wonder if perhaps change is the ultimate silver lining. Thank you for your time, and we're happy to take questions.